Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I've been having this numbness in my fingers, particularly when I'm driving or holding something for too long. It gets quite bothersome. My hands have this history of arthritis, which I know is playing a big part in this. Mornings are the worst. I sometimes struggle to make a fist. I've tried various things over the years, natural therapies, mostly. I'm not big on medication. I've always been worried about long-term effects on my liver and kidneys.
I understand your concerns about medications. It's good to hear you're proactive about seeking alternatives. Could you tell me a bit more about these treatments you've tried? Also, any other medical interventions or injuries in the past that could be relevant?
Sure. Well, several years ago I tried prolotherapy for my knee. It didn't really help with the arthritis there, but I found it somewhat helpful for minor joint pains. For my hands, I haven't found anything that provides long-term relief. I've also had cryotherapy for a skin issue, which worked well, but that's about it for interventions. I had a significant cut on my finger when I was younger. It healed okay, but it used to get numb in the cold. I guess that was my first encounter with numbness. As for injuries, there was a fall that injured my shoulder. It still bothers me occasionally, and I wonder if it's connected to the numbness now.
Interesting. The history of your finger injury and your shoulder could indeed be contributing factors to your current symptoms. Do you notice any particular activities or positions that make the numbness worse, besides driving?
Yes, when I use my phone for too long, or if I'm holding a book. It's like I have to keep changing positions to avoid the numbness. It's really frustrating, especially since I spend a lot of time reading. I've adjusted my diet, added more anti-inflammatory foods, and I practice some exercises that are supposed to help with arthritis. I still do my daily exercises, trying to keep everything moving.
Your approach to managing this with lifestyle changes and exercises is excellent. It's also good to know that you are maintaining an active routine. Let's go over some of the physical findings and what they suggest. During the examination, I noted a decreased range of motion in metacarpophalangeal joints, especially on the left side where you experience more numbness. There's also some crepitus and mild swelling, which are typical of osteoarthritis. The X-rays of your hands and wrists show joint space narrowing, subchondral sclerosis, and the presence of small bone spurs, confirming osteoarthritis.
I was expecting it might be arthritis worsening, but the numbness was something new. Do you think the shoulder injury could be tied to this?
It's possible. Mild degenerative changes in the cervical spine could contribute to such symptoms, although your X-rays didn't show significant stenosis or nerve root impingement. Given your shoulder history and these findings, it's likely a combination of factors, including the arthritis in your hands.
What do you suggest we do next?
Given your preference for non-medical treatments, I would recommend continuing with the dietary modifications and exercises you find beneficial. However, it might be helpful to explore physical therapy specifically targeted at your hands and shoulder. This could improve mobility and possibly reduce the numbness you're experiencing. I also suggest we take a follow-up X-ray in a few months to monitor the progression of the arthritis and reassess if there's any change in your spine that could be influencing your symptoms. We could also consider consulting with a specialist in rheumatology or a hand specialist to get another perspective.
That sounds like a plan. I'm willing to try the physical therapy and see if that makes a difference. I appreciate your understanding of my concerns about medication.
Absolutely. It's important to find a treatment plan that you're comfortable with. We'll schedule the follow-up X-rays, and I'll arrange a referral to physical therapy. Let's meet again after that to discuss how you're doing and decide on any further steps. Your proactive approach is very beneficial, and continuing that will be key moving forward.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been quite worried about starting radiation therapy for my prostate cancer. It's all new to me, and I don't know what to expect. I've been on hormone therapy injections, which have been manageable, but this next step feels daunting.
I understand your concerns. Radiation therapy can sound intimidating, but it is a well-established treatment. We'll be monitoring you closely throughout the process. How have you been feeling otherwise? Any new symptoms or concerns since your last visit?
Actually, yes. I've noticed my heart feels like it skips a beat sometimes, more than before. It started a few months ago, and it's a bit unsettling.
We did discuss your occasional irregular heartbeats last time. The Holter monitor will help us understand if there's a pattern or a specific cause we need to address. It's good you mentioned it.
Also about the cough that never seems to go away. No matter what I do, it's always there. It's frustrating not knowing what triggers it.
Yes, we suspect it might be linked to medications or possibly allergies. We discussed trying some new treatments to see if they might help with that. Have you noticed any changes or patterns that could give us more clues?
No specific patterns, but it does seem worse at night. I haven't started the new medications yet. I was hoping to discuss this further with you first.
We'll definitely explore that. Nighttime worsening could point towards reflux, which we thought might be contributing. We can start treatment for that and see if there's any improvement.
And another thing on my mind has been my diabetes management. My blood sugar has been bordering higher lately. I've been careful with my diet, but it seems harder to control.
Managing diabetes effectively is crucial, especially with your current treatments. We might consider starting metformin to help with blood sugar levels, depending on your next lab results. It's good that you're monitoring it closely.
I've also been struggling with my vision. It gets blurry at times, even with my glasses on. I know we talked about diabetes possibly affecting my eyes.
Yes, diabetes can cause changes in your vision by affecting the lens of your eye. Updated eye exam is essential, and we should schedule that soon. Blurriness can be a sign of other eye conditions too, so a thorough checkup is necessary.
I'm also trying to keep up with the walking, as you suggested for my general health, but my right knee has been giving me more trouble. It's the same knee I had issues with in the past.
It's important to keep active, but not at the expense of causing more pain or damage to your knee. We might need to look at other low-impact exercises that won't strain your knee as much. Swimming or cycling could be good alternatives.
Lastly, with all these treatments and tests, keeping track of everything feels overwhelming at times.
And I can imagine it does feel overwhelming. Let's make sure our plans are clear and manageable. I'll summarize the main points for you. First, for your prostate cancer, radiation therapy is scheduled to start next week. We'll continue with the hormone therapy as it's part of your treatment plan. Regarding your heart, we'll arrange the Holter monitor as soon as one becomes available to assess the irregular heartbeats. For the chronic cough, let's start treatment for reflux and monitor if there's any improvement. Your diabetes will need close watching. We might add metformin based on your upcoming lab results. Also, we'll update your referral for an eye exam. For your knee, consider switching to swimming or cycling to reduce strain. And finally, we'll schedule a follow-up in 3 months to review everything. But if there are any issues, or if the lab results bring up new concerns, we should follow up sooner. Does that plan sound okay to you?
Yes, doctor, that sounds comprehensive. Thank you for laying it all out. It helps to have a clear plan moving forward.
Absolutely. I'm here to help make this manageable for you. Don't hesitate to reach out if anything concerns you before our next scheduled visit.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good afternoon, everyone. Today I want to discuss the significant healthcare challenges faced by incarcerated individuals with chronic illnesses. These individuals often experience delayed diagnoses and inadequate treatment.
Exactly, and it's crucial to acknowledge that the environment in prisons can exacerbate existing health conditions due to stress, overcrowding, and limited access to necessary medical care.
Furthermore, there's a lack of continuity in care when inmates are transferred between facilities or released, leading to worsening health outcomes. It's not just a prison issue, it's a public health issue.
We need to consider implementing better training for prison staff on recognizing symptoms and managing chronic diseases. Also, establishing partnerships with community health services could improve continuity of care.
Indeed. We should also push for policy reforms that ensure inmates have the same rights to health care as the general population. It's essential for ethical and practical reasons.
In closing, by addressing these challenges, we can significantly improve health outcomes for incarcerated individuals and ultimately contribute to better public health.
Now look at question 26.
We have a case of malignant hyperthermia. I need everyone to act swiftly. First, let's get the dantrolene. We need to administer it as quickly as possible.
I'm on it. Dantrolene coming up. Also, cooling measures need to be started immediately. Let's get ice packs and cooling blankets ready.
Correct. Let's also ensure that the anesthesia team switches off all volatile anesthetic agents and uses 100% oxygen. We need to flush the system.
Blood gas and electrolytes are being drawn now. I will also monitor the patient's heart rhythm closely for any signs of arrhythmia.
Keep a close eye on the core temperature and CO2 levels. We need to manage this aggressively to prevent any complications. Everyone, stay focused and keep communicating.
Now look at question 27.
Managing severe asthma in children involves more than just medications. It's crucial to identify and avoid environmental triggers.
Absolutely, the role of allergen exposure can't be understated. Parents often need guidance on reducing dust mites, pet dander, and mold in the home.
And don't forget about tobacco smoke and air pollution. These are significant triggers that can exacerbate asthma symptoms and lead to more frequent exacerbations.
Education is key. We should be working with families to create asthma action plans that not only cover medication use, but also strategies to avoid triggers.
Let's also discuss the potential benefits of newer biologic therapies in managing severe cases. These can be game changers for the right candidates.
Now look at question 28.
Egg freezing for non-medical reasons is becoming more popular, but it raises ethical questions. We need to consider the implications for women and society.
One concern is the commercialization of fertility. Are we encouraging women to delay parenthood for career or other societal pressures?
That's a valid point. It's also important to discuss the risks involved with the procedures and ensure women are fully informed before making these decisions.
Absolutely, informed consent is critical. We should also consider the psychological impacts and the pressures that might arise from having these options available.
True, the technology offers more reproductive autonomy, but it's our responsibility to ensure it's used ethically and not exploitatively.
Now look at question 29.
I understand that being diagnosed with chronic hepatitis C can be overwhelming, but many effective treatments can help manage this condition.
What does the treatment involve, and what should I expect in terms of outcomes?
Treatment typically involves antiviral medications that you'll take for a few months. Most people respond very well and can even be cured of the virus.
That's reassuring. Are there any side effects I should be aware of?
Some people experience mild side effects like headaches or fatigue, but these are generally manageable. I'll monitor your health closely throughout the treatment.
Now look at question 30.
Clinical transparency is essential for patient trust and safety. We must disclose more about treatment outcomes and potential risks.
While transparency is important, we also need to consider how this information is presented to avoid causing unnecessary anxiety or misinterpretation.
True, but withholding information can undermine trust. Patients deserve to know what to expect from their treatments, including any potential negative outcomes.
It's about finding the right balance. We need to be honest and clear, but also supportive and reassuring. Educating patients on interpreting clinical information is key.
Agreed. Enhancing transparency also encourages healthcare providers to maintain high standards of care.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Today, I am excited to delve into a transformative approach in the treatment of Parkinson's disease through the integration of connectomic targeting and artificial intelligence in deep brain stimulation, or DBS. This methodology not only enhances the precision of our interventions, but also tailors them uniquely to each patient's neurological landscape. Let's start by understanding the basic premise of DBS. Traditionally, DBS has been employed to modulate dysfunctional neural circuits, commonly targeting areas like the subthalamic nucleus (STN) or the globus pallidus interna (GPI), for alleviating motor symptoms in Parkinson's disease. While effective, the one-size-fits-all targeting approach often leads to varied outcomes because of the complex and heterogeneous nature of neural degeneration in Parkinson's. Recent advancements in neuroimaging, particularly connectomic analyses, provide us with a detailed map of a patient's brain circuitry. These maps reveal the connections and the intensity of neural pathways, allowing us to pinpoint more precisely where the DBS electrodes should be placed for optimal effect. Connectomic targeting thus promises a significant leap from the traditional methods by offering a customized approach based on the individual's unique neural architecture. To illustrate this, let's consider a case study of a 63-year-old patient diagnosed with tremor-dominant Parkinson's disease. The patient exhibited significant tremor, but minimal rigidity and bradykinesia, which are typically responsive to standard STN-DBS. However, due to the tremor dominance, our team opted for a dual-target DBS strategy, aiming both at the STN for its proximity to the dentatorubro-thalamic tract, DRTT, a key player in tremorgenesis, and the ventral intermediate nucleus, VIM, of the thalamus, which is specifically effective in tremor control. Using connectomic data derived from high-resolution 7 Tesla MRI scans, we tailored the electrode placement in such a way that it would best intersect the relevant pathways implicated in this patient's tremor. Moreover, integrating AI with this data allowed us to simulate various scenarios of electrode activation before actual surgery, enhancing our accuracy in targeting and predicting the outcomes. Post-surgery, the patient showed a remarkable 90% reduction in tremor with minimal side effects, a significant improvement over the average 50 to 60% reduction seen with traditional methods. This case exemplifies how patient-specific connectomic data combined with AI-driven simulation can revolutionize personalized medicine in DBS. Furthermore, the role of AI doesn't stop at planning and simulation. Post-operative adjustments and settings are often a lengthy trial-and-error process that can extend over several months. AI can expedite this by analyzing immediate post-op results and ongoing patient feedback to adjust stimulation parameters in real time, drastically improving both the efficacy and the efficiency of symptom control. However, this approach does not come without challenges. The high-resolution imaging and computational requirements for connectomic analysis and AI integration are resource-intensive. Moreover, the clinical interpretation of complex connectomic data requires extensive training and collaboration across multidisciplinary teams, including neurologists, neurosurgeons, and data scientists. As we look towards the future, the ongoing collaboration between clinical neuroscience and technological innovation holds the key to unlocking highly effective, personalized treatments for Parkinson's and potentially other neurological disorders. By harnessing the power of AI and connectomics, we can move beyond the limitations of traditional DBS, offering patients tailored therapies that directly target their unique disease pathology, leading to better outcomes and quality of life. While the integration of connectomic targeting and AI in DBS is still evolving, its potential to transform the landscape of neurosurgical interventions is immense. Continued research and interdisciplinary collaboration will be crucial in overcoming the existing barriers and realizing the full potential of this promising field.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good morning, everyone. Thank you for joining today's session. My name is Dr. Jonathan Phillips, and I'm delighted to present a recent case that highlights the complexities and advancements in managing solitary fibrous tumors, SFTs, particularly those located in the central nervous system, CNS. This presentation aims to elucidate our multidisciplinary approach, emphasizing the importance of integrating current research into clinical practice. Solitary fibrous tumors, as many of you might know, are rare mesenchymal tumors that can occur anywhere in the body but are infrequently found in the CNS. They represent a diagnostic and therapeutic challenge due to their varied presentations and unpredictable behavior. Today, I'll discuss the case of a 58-year-old male, referred to as Mr. A, who presented with intermittent headaches and a recent onset of numbness in his left shoulder and upper extremity. Mr. A initially sought treatment from his primary care provider, who performed a comprehensive cardiovascular workup based on symptoms that turned out to be normal. However, worsening of his symptoms led to an MRI at a local hospital, revealing a posterior fossa mass. This finding necessitated his referral to our specialized center for further evaluation. Upon presentation, our team conducted a thorough neurological examination, which was notable for a tongue deviation to the right, suggesting possible involvement of the cranial nerve Thwevin. This clinical sign raised concerns about the mass exerting pressure or causing direct neurological damage. An MRI conducted at our center confirmed the presence of a large, heterogeneously enhancing mass in the posterior fossa, compressing the brainstem and adjacent to the fourth ventricle. Given the complexity and location of the mass, and the severe symptoms exhibited by Mr. A, the decision was made to proceed with surgical intervention. The surgical strategy was meticulously planned, incorporating intraoperative neuronavigation and neuromonitoring to maximize tumor resection while preserving neurological function. The operation involved a midline suboccipital craniotomy and was successful in achieving gross total resection of the tumor. Histopathological examination of the surgical specimen was crucial in establishing a definitive diagnosis. The tumor was found to be a solitary fibrous tumor, WHO CNS grade 1, characterized by spindle cells and collagenous stroma, negative for EMA, and positive for STAT6, confirming the diagnosis. Postoperatively, Mr. A showed remarkable neurological improvement. His headache resolved completely, and the numbness in his arm diminished significantly. He was discharged on postoperative day 2 with a tapering dose of steroids. This case underscores the critical role of a multidisciplinary team in the management of complex intracranial tumors. From initial assessment through surgical intervention and postoperative care, collaboration across specialties ensured optimal outcomes for Mr. A. Solitary fibrous tumors of the CNS, though rare, can cause significant neurological deficits and morbidity. Advances in surgical techniques, coupled with improved diagnostic capabilities, allow for better management of these challenging cases. Future research should focus on understanding the biological behavior of SFTs and exploring adjuvant therapies to prevent recurrence, especially in higher-grade tumors. Thank you all for your attention. I look forward to any questions or discussions regarding this intriguing case and the broader implications for managing rare CNS tumors.